Okay, and welcome again to It's Only MSK Ultrasound. Thanks for joining us. My name is Stuart Wildman.
I'm Dave Baker.
And I'm Rob Mast.
Thanks, boys. It's good to have you back from your extended summer break.
Indeed.
Dave, it looks like you left your factor 50 at home this time. Quite bronzed.
Yeah, well, I was in sunny Southwold for a little while.
Oh.
So,
Very nice.
catching some rays.
Some ice cream down there.
More like Costa del Sol kind of colours, Dave.
Yeah.
Yeah, man. It's more your style, I thought. But
So we're getting back into the swing of things, and as we know, it's a busy period now for us from a teaching perspective. We're kicking back off with our Brunel program, which has been really successful again. The 3 programs all kicked off today for the PG Cert, the foot and ankle PG Cert, and our exciting ultrasound in practice program open to people now across the globe, of which we've got a number of students who have joined us for the first time, which is really, really exciting. But we're back in here tonight on the pod and looking to just elaborate on a few points that have come in from a number of emails over the last couple of weeks. And there seems to be a general movement, I think, towards exploring guided injections and people looking to take their practice in that direction, whether that's because of patient demand or whether it's because of clinicians generally now seeing a shift in best practice towards guided injections. I'm not sure, but I'm getting a number of questions coming in, guys, that I thought we could answer or maybe just explore and discuss, because this is an area of clinical practice where there isn't an answer, is there, necessarily? There's not a textbook you can go to for an answer. There's not a website where it says you must do this, this, and this, and that's a common message with ultrasound. But one of the questions that I do get in quite frequent, and I seem to, for whatever reason, had quite a few in the last few weeks, is I work as an MSK clinician, and that can be a physio, that can be a sports and exercise medicine consultant, that could be a sonographer, that could be a podiatrist, that could be anybody. What is the best way to start doing guided injections when I've been doing landmark guided injections for many years? And I think that's the crux of the issue, that a lot of people are unsure where to go with their training and why they should do things in a certain way. So yeah, I'll throw it open to you, boys, and what your thoughts are on this.
Yeah. Well, as you say, this is definitely a question we get asked a lot, and certainly, oftentimes people sort of, like, how do I make that move from, well, if they're doing surface marked injections, move to ultrasound guided injections? I mean, I always, my starting point when answering this is, what does an ultrasound guided injection, what are the advantages of an ultrasound guided injection? And, we've done I think we did a little sort of podcast on this, so we won't go into too much detail, but I think that, I think in very broad summary, the advantages in terms of clinical outcomes, etc., of doing an ultrasound guided injection are quite marginal. Yeah, I think we can say it's quite a marginal benefit in terms of treatment outcomes, etc. But most of the advantages, really, we're looking much more at, things like accuracy of needle placement, reducing risk of trauma. Got obviously sort of medico-legal aspects of it, being able to record where the needle was. We can talk also about some of the advancing practices in terms of like procedures that may, in all likelihood, require ultrasound guidance if we're thinking of it like barbotage, high volume, etc. So in summary, what I always would say to people is that really the advantages of performing an ultrasound guided injection over a surface marked or landmark guided injection really depend on you knowing what you're looking at, by and large.
Well, that's the big question, isn't it? The question is always like, I've done a medial approach to the knee for ages, or I've done subacromial injections for ages. Can I just pick up an ultrasound probe and stick it on, and then Eureka, I'll see the needle, and off we go?
Yeah. I would say no. I'd say it's a difficult skill to pick up, and I would also say that if you don't really understand what you're looking at on the machine, then the advantages are probably non-existent, and
Yeah.
and there are also disadvantages, and we've talked
Yeah.
about this before, haven't we? Like that, like the journey of the needle is oftentimes longer to the target structure when you're doing it under ultrasound guided than if you're doing it landmark guided. And so, in actual fact, you've got more risk of pain and possibly needle trauma doing it ultrasound guided than not. Plus the facts that that there's possibly some marginal uptick in terms of risk of infection. So it's not even to say what I know that there's a bit of a sort of culture, certainly in the past. I know Rob sort of has, people.
What is he going to say now?
But it can only make you better, and it can only make you more accurate.
That's my
Not convinced that that's the case, and then it also sidesteps a lot of the potential disadvantage. It's a long learning curve, I think, before it gives you any advantage.
Yeah, no, totally, mate. But what I'm just thinking of now, it's our journey, yeah, because we all come from the same. We all like physios. We all did landmark guided injections probably for quite a few years.
Yeah.
And we were all allowed, and I never felt there was this sort of absolute need for me to immediately start switching to go to ultrasound guided. And that was probably because we were on this journey to, get introduced to ultrasound, to learn the diagnostic side of it, and then gradually go into it. But I think people coming into it now, a bit later to the party, if you like, when it's much more established now that ultrasound guided injection is the kind of thing that lots of people are striving for. There is, I think, a more an acute sort of pressure almost for people, or that's what they feel maybe, or their surfaces might put some pressure on them saying, oh, you're going to do an ultrasound guide injection course. Great, because we're kind of, really would like you to be able to start doing that soon. And I think that's why that question might be coming up a lot more now, because I can't remember it coming up so much like 10, 15 years ago, for example.
And do you think that that's partly because there is this sort of lack of, if you like, insight of what the relative merits of guided versus unguided are? Because I think to the sort of almost like the shortcut from thinking perspective is that ultrasound guided injections are inherently superior to a landmark guided injection. They give you better outcomes. You're more like, now I get lots of people refer to me that, that they've had 3 injections, landmark guided, none of them worked. Now we want an ultrasound guided one, which, and I'm always a little bit sort of, and manage expectations around that, because I think to think that there is just a baked in superiority in terms of likelihood of success is really a naive.
No, and I think it's that whole thing around, I don't want to go off topic too much. The whole thing about success of a patient responding to an injection of whatever sort comes back down to the reason and the rationale behind patient selection, doesn't it? That's the crux of it.
Yeah.
I just want to bring you back to, there's an interesting point we talked about in terms of that ability to use ultrasound. So if somebody's saying, I've done landmark guided for a long time, and we're saying what we just mentioned earlier, that there should be some skills around ultrasound and the ability to utilize ultrasound. What is it about using ultrasound that means that people should have some training and competency before they start using ultrasound as part of an injection process? What are the relative risks around it in terms of the appearance and things?
Yeah, well, I mean, I'd rewind even one step further than that.
Right.
And so probe handling skills and dexterity, the motor skills need to be built up.
True.
Yeah. And that relates, I guess, to for those people who are less familiar with the technique of doing a guided injection, is, I guess, what we're talking about there is just that ability, isn't it? And we mentioned it today in the teaching with our students, was that holding the probe when you first do it feels really alien. It's not an easy thing to manipulate, and we're talking about a narrow probe width. I can't remember. I should really know this probably, how wide a probe is. And you've got a needle that's super thin. It's not an easy thing, is it, to pick up straight away? And as you say, that that familiarity of moving the probe, ensuring that you're seeing the right part of the needle that you think you should
Yeah.
see.
Yeah. So the
Yeah.
beam width's, barely a millimeter, and you're trying to balance
Knowledge, Dave. Good
something
physics
that's
knowledge.
barely a millimeter wide
Excellent.
on top of something that's, a fraction of a millimeter
Yeah.
wide.
Yeah.
It's not easy, and also just holding a probe whilst performing an injection. I mean, we know, because we've been teaching it for years, actually gaining that skill, keeping the picture static on the screen,
it's just
taking the needle, putting the needle in, and then being able to advance the needle without the probe moving.
So difficult, isn't it?
It takes a long time.
Yeah. But then also, I was just thinking, like if you start learning ultrasound, you learn everything, well, almost your anatomy, you have to relearn to some degree, don't you? Because you have your ultrasound probe, you've got your skin, you've got your fat, you've got, and you have to, and then in cross section, you have to have a real map in your head of what's medial, what's like radial, ulnar, or so, let's say a wrist. If you do carpal tunnel injection, for example, and you do that, you've done it for years, like you said, unguided. So you had a very good landmark that you always felt worked well, never left you alone. You go through it, you probably only have to go a few millimeters deep and you're in the tunnel anyway. But then if you do it sort of in an ultrasound guided way, you would do it cross-sectional, and then all of a sudden you've got an ulnar nerve that sits potentially in the way if you come from that side that you never probably had in your mind. So as you said, if you think, well, actually, I now do it ultrasound guided, so I'm safer, then you might be in for a surprise if you're not totally on it in terms of your skills and not totally on it in terms of where everything is in your mind and on that ultrasound screen, because that's what you're looking at. You're not looking at the patient's wrist as such, you're looking at your screen. It's a completely different thing, isn't it?
I think it's really interesting, isn't it? How we, just sitting here, my head's buzzing because there's so many different parts of why somebody should understand ultrasound before they start sticking needles in and trying to see them under ultrasound, right? You've talked there about, sort of techniques and approaches, anatomy. Dave's talked about probe handling. You've got the issue around just being able to differentiate grey. Yeah, it's a grey image, and if someone hasn't sat with you and you haven't spent, at least a couple of days, actually properly scanning through, looking at structures, saying, like, that's a tendon, that's a nerve, and then, things like what an art, I always put that first CMC joint picture on our courses, the injection courses, don't I? Where you've got kind of, the radial artery, that you've got a venous structure, you've got a part of the joint capsule, which are all sort of dark, or for people who aren't familiar with it, we call black things on ultrasound anechoic. We call darker grey things hypoechoic, just because we like to create extra jargon and a different language to make things even more difficult for you. But they all look very similar, right? And if you don't know how to use Doppler to pick up a vessel and evaluate these areas and understand the anatomy, I just don't understand how you can be confident that you're not injecting the wrong, how can you be confident you're injecting the right structure and not injecting the wrong structure, but also off the back of that, you then sort of start to think, okay, well, if I'm trying to inject this and that, but go back to the probe, my probe angle isn't right. And we talked about anisotropy today at length on some of the lectures in the physics content. Is again, it comes back to probe skills and probe orientation, and it's endless, isn't it? And I totally understand that if you don't use ultrasound, you don't have an appreciation of this complexity, I don't think.
No.
Yeah. So we're saying that the very fact of learning musculoskeletal ultrasound, you relearn your anatomy, you relearn your appreciation of structures. I would also say that it would be I would imagine, extremely difficult to really learn to be able to understand the different nature of the different tissue types and the layers and everything if you weren't performing some sort of dynamic scans at some point, because you're learning literally by focus scan positions only. Say, right, okay, this is how you're going to do a shoulder, that's a humeral head, that's a capsule, whatever. You're not really learning very well, in my opinion anyway, not in any sort of depth that's going to allow you then to be able to sort of carry over. You're not going to get any sort of carryover of skill in a way to the next area that you scan. I mean, some bits
Yeah.
are obvious, so maybe bone and joint margins and stuff like that. But if you're doing injections around, you know, some of the more sort of complex areas, carpal tunnel, this, that, and the other, I would just be thinking, I don't know how you would learn what the different tissue types look like and the appreciation of the layers and everything like that. If literally all you are ever going to learn is plonk the probe here, you are just looking to make this image on the screen, and this is where your needle's going to come. It's going to be so two-dimensional, if you like, in terms of your understanding of the and I all come back again to, and therefore the vast majority of the benefits of ultrasound are then just lost in transit.
Yeah. It's interesting, isn't it? There isn't clarity for people, I don't think, at the moment. It is very sort of opinion based. Like we're talking about it tonight here, right? From, I guess, relatively experienced sort of perspectives, and that we've been lucky that we've sort of lived this journey and together and have reflected on it excessively, arguably. You know, but there is no guidance for people out there around it in particular, are there? I mean, I always, you know, when we do the talk, I do the talk in the cadaveric course, for example, and I put up, which I think is a very clever slide, but I'm sure it probably isn't. But I get very excited about this slide every time I talk about it, which is the one with the drill, where I say, you know, if you're going to drill a hole through a wall, do you need to know how to use the drill, right? Which I think is a moment of genius, quite frankly, in terms of PowerPoint creation and development.
That's from the DIY course that you teach on the side.
Yeah, I think you're referring to the DIY course that my wife is very keen to send me on, because I still don't know how to use the drill, and there's multiple areas of evidence of that in our house. But it is, isn't it? It's like, you know, if you don't know how to use it, when you think about that part of it, you also then think, well, you've actually got to know how to use the machine, right? Your area of expertise, Rob, is around, you know, machine settings and all those little bits, you know, as you enjoy. And it's, you know, like, do people understand how to change the depth, right? If you're going to do a hip joint injection, right, and you don't know how to use an ultrasound probe, and you go up to an ultrasound probe, you pick up a linear probe, and you've got maybe a slightly larger patient, and you can't see the hip joint. How are you going to get to the hip? How are you going to see the hip joint to do the technique if you don't know how to use the ultrasound machine?
And we do it instinctively, because we've done it for so long, I think. But let's go. I just want to almost go back a bit to that very early stage when we started doing it. Like, if we think about it, relatively very few people were doing MSK ultrasound at the time. You remember, like, we were doing these sessions in the evening when we got a whole load of people from all over, sometimes from way out of London, coming to these sessions, and they're from all different professions. And we were all kind of learning it together a bit. So the pace was actually, no one was expecting to be good at it quickly, you know, and we've been allowed to develop this over years. So I think that gave us the confidence, I guess, ultimately at certain stage that we thought, well, actually, we now can consistently see this. But I sometimes feel that people jump into ultrasound and almost feel obliged to perform at a level very close to, you know, where we are, for example. We've been doing it for many years, and I don't, you know, it's just such a, like you said, you've got all these factors that we were just mentioning, and then you put into body habitus, individual variations. You know, some people difficult to scan because their skin is dry or their hair, whatever. You mix it all in there, it becomes an absolute minefield in some ways. I mean, we don't want to put people off.
No, we're not. Just don't do it. That's the easiest. But it is a difficult skill to learn, right? And I think you have to be honest about that it is a difficult skill. I mean, I remember learning it, and I wouldn't say I'm a natural injector. You know, I think, Rob, you're probably much more natural. I mean, both of you are much more natural. I'm not a natural injector, I don't think. And to some people, these skills come much quicker. To others, you know, they take a bit longer. And
but that's also really important, mate. If you kind of recognize that, and then, for example, you want to do an
Yeah.
injection, you think, well, actually, no, I don't want to, and sometimes just say no. And that's so powerful, because I think sometimes when people feel that they should be doing it because they have got some expertise, and they actually like don't feel confident enough, and they might make an error, and they
Well,
poke their
yeah,
nose
but
out. What
I
happened?
also think when we talk about what the drivers of people do for transition from landmark to guided, and if you think
Mm,
about
mm,
maybe sort of healthcare services and waits for patients' appointments and that kind of stuff at
mm,
the moment, I think there is a pressure sometimes to perhaps offload services who do a lot of guided procedures and bring those services elsewhere, right? Whether it's
mm,
a
mm,
community service or whatever, to try and improve patient pathways, help with getting patients, getting it right first time,
mm.
go for all that kind of stuff.
Yeah.
But I'm not always sure that the people who are making those decisions about saying, well, we're going to set up this, we're
Yeah.
going to set up that, understand the challenges of
No.
how
No.
difficult it is to
Mm,
do these procedures, but
Yeah.
also what's required to build somebody up in a sensible way to the
mm,
point where they're actually confident to do it.
mm,
And I'm always quite protective of physios who sort of can find themselves in those sort of positions. And I often sort of say to them,
mm,
don't be pushed into this too fast, because as we know, sometimes these procedures can take longer. Sometimes they can, you can be doing more intricate
mm.
things. It's not the sort of thing to be rushed. And I guess
No.
so. What we're saying here, and it's always good, isn't it, to try and we're
Mhm.
all we're all always very good, us three, aren't we, about banging on about all sorts of bits and pieces and chatting about things. But so what we're saying here is that we think that people who are going to look at doing guided injections, who have done landmark for several years, we're saying that we think that having an ultrasound skill set. I'm not going to use the word competency, because I don't think, without the whole issue around one course of training for ultrasound, I don't think you can ever sort of say they should do one thing. But we're saying that people should develop an ultrasound skill set to be able to manipulate the probe, understand the machine settings, understand what they're looking at, for example,
Yeah.
identify common pathologies,
Yeah.
uh, and identify the unexpected as well, potentially to some extent.
Yeah.
And then as soon as you start listing those things, you realize actually that you need to have a decent level of competency, don't you? And I'm not going to start saying that people, what is the minimum that somebody should do, or what is the maximum that someone should do. I think that's just starts to get a bit difficult. But that's what we're saying here, isn't it? I think.
Yeah, and
Mhm.
I think we've touched on this point a couple of times during the discussion, and that is that not all ultrasound guided injections are created equally in terms of like complexity. So, yeah,
Mhm.
I would say that for example, I don't know if you're doing a knee injection
Yeah.
or a lateral hip, trochanteric bursa type one, that that is a much more straightforward
Mm,
technical, but also in terms of like risk of
mhm.
it causing more pain or causing injury or whatever. So those ones, people can start to sort of build
Mm.
their skills. And if I'm sort of mentoring some, people, I'll be happy for them to sort of start developing some sort of independence on those structures. But then
Yep.
if you move into like a dequervans or a carpal tunnel or something like that, to me, those are sort of end stages when you've done a few hundred and you've got really good control of advancing the needle. We talk about these sort of classic sort of cross-cut artifacts where
Mm.
people are sort of following what they think is the tip of the needle, and then they adjust the probe and they find they've actually gone about an inch and
Just,
a half
just
further than they
I've gone
realize.
through the nerve.
Dave, true to form, you're just dropping some massively geeky terms there in terms of ultrasound and guide inject. Just
Yeah,
explain that for those who are less
I'm
familiar.
sure you'll be able to stick a little pictorial over the top of it, as I said.
Yeah.
Cross-cut artifact is essentially, where the probe isn't sort of sat on top of the needle. I'm doing it with my hands now; it's quite difficult. And so you're cutting across the needle, as the name
Yeah, and the
suggests.
probe wants to be parallel with the
Yeah,
needle. That's the
and
rough way of it.
and as you advance the needle, because the probe is cutting across it, the needle doesn't look like it's actually getting any further advanced
Yeah,
until you straighten the probe up on it, and then you find it's actually gone way, way further into the
yeah,
tissue than you realise. Now, again, if you're doing that, if that's a knee, that's a trochanteric bursa, something of that nature, probably wouldn't matter too much. That's a carpal tunnel. Yeah, that could be a little bit more problematic.
Yeah, absolutely. I don't think necessarily. And why would you? You think, oh, I can just pop the probe and I can see the needle. The needle's going to be really bright and obvious. There's so many sort of intricacies to it, aren't there, around these sorts of things.
Yeah.
Um,
So we're saying a solid grounding in ultrasound, and as you say, and a good appreciation of things like the physics of the ultrasound, how to optimize the image, and what the different tissues are. It's all very well putting your probe on and advancing a needle, but if you're going, what's that red flashing thing when I put the Doppler on? And you don't have that appreciation of what's actually on your screen and the relevance of it, ultrasound's giving you absolutely no advantage at all. And as we said, actually, it may give you some disadvantage. I was actually scribbling down a couple of other points
brilliant.
As Rob was talking. I was trying.
Can't wait for them, Dave. Send them.
Keep yourself awake as much as anything else. I tried thrashing myself with stinging nettles, and then
okay, there better be good points now, Dave. Come on,
launch them. Count the island's finest points. Let's go. Come on.
Yeah. If you don't know what you're looking at, so you could. This is like worst case scenario, I guess, is that you could take some images of your injection and take some lovely pictures of the needle, but there could actually be some sort of sinister pathology or some sort of worrying other structure in the field of view that you've taken the image of, which, again, from a sort of medico-legal perspective, if you've proceeded with that injection and they said, well, anyone who was reasonably performing an ultrasound or reasonably performing an ultrasound-guided injection should have questioned what that was on their screen, that was a sort of a throbbing mass of Doppler right next to where they introduced their injections. So that's kind of almost like worst case scenario, and I sort of work back from there. You could have something on there that, if it was not sinister pathology, it could either be a contraindication or a relative contraindication to an injection. And here you could think about, imagine if you were doing an injection, I don't know, in a rotator cuff, you're doing an injection into the subacromial subdeltoid bursa, but actually, right where you were doing the injection, there was a close to full thickness tear of the tendon, and you proceeded with the injection, and then the person went on to rupture the tendon. Then you may have some, questions around, and I think I've mentioned this to you before. I had a patient sent to me who had a report which said that there was no damage to the structures around their shoulder, but when I scanned them, they actually had a full thickness tear. Had I have proceeded with that injection and the patient hadn't got better, and they'd have then had a further imaging, and then they said, well, actually, you've got a full thickness tear. Again, we're talking, once in a lifetime or once in a career time or whatever, but you could see a scenario whereby you might then get blamed for that tear that wasn't previously picked up. So
it's interesting, isn't it? It's interesting that there has to be a level of acceptance. I think that yes, our clinical exams and our clinical tests, right, take us a long way towards both subjectively and objectively towards a firm diagnosis and coming to a clinical conclusion that we can then plan a patient's treatment off of. But you can't get away from the fact that as soon as that there are a number of scenarios and cases and situations that come up fairly frequently where, by putting the ultrasound probe on and gaining more information, it can sometimes change your decision making around whether it's safe and appropriate to proceed with an injection as well, right? And that's what you're getting at, Dave. As soon as you put that on, you're actually how can we separate out the ability to actually diagnose or do a diagnostic scan from a guided injection?
I guess the specific point that I'm getting to here, and I'll give you a couple of, and I know I've mentioned, so I think I've even presented these cases as part of the course.
Of course you have.
two scenarios. Two scenarios. One was glass in a foot in the first metatarsal phalangeal joint that was sent to me for an ultrasound guided injection. And again, it was really, you could have easily missed it, but you could see there was an artifact within the capsule of the first metatarsal phalangeal joint, and it had already started to, get some, degree of sepsis within the joint. And I also had a iliotibial band where it was actually, they had a rose thorn in the iliotibial band. And again, where I was being asked to inject, there was already an infection starting to brew. So, these are other cases where, if in a case where you'd proceeded with the injection and you then sort of got asked for the images, they'd be like, well, hold on a minute. You can see there's a foreign body in there and you still continued with your injection. So these are...
Yeah, and Dave, that's a good point. But, we often talk about POCUS as in point of care ultrasound, and it not always images being saved and stuff. And I think both yourself and myself work privately, and I believe we do store the images. And then from that point of view, I mean, I'm not saying don't store images, but that makes that even more important that your report correlates with actually if someone else looks at your images and it's hang on. He didn't mention that, but that can happen.
What I'm alluding to, isn't it, is that your images are your safety net. They're your safeguard. They're your proof that you did, that you did a reasonable technique and that all due diligence was taken. But if you don't know what you're looking at and you actually save images which actually do the very reverse and are actually implicit that you didn't really know what you would, or you certainly didn't understand what you were looking at on the image. I think that's a tricky one, probably from a sort of, I don't know, from a medico-legal perspective, in terms of the fact that you've then proceeded with an ultrasound guided injection with something on the image which should have at least made you, sort of stop and take stock of the situation before proceeding.
I think. I think another interesting point, and I'm conscious of time, we should probably think about wrapping up, is around how, one of the big benefits, and you've already sort of touched on this, Dave, and obviously, you've gone straight for the critical points within the first 30 seconds and blowing the podcast out. So I've had to repair it ever since, quite frankly, the last 45 minutes. But the thought about, again, why develop ultrasound skills? Well, because having the ultrasound skills actually helps you improve your technique. It helps you reduce patient discomfort. You think about examples. You were talking about the knee there, Rob, and I was sort of thinking, people may say, oh, I've done landmark guide injections of the knee for years. I'll just start doing them guided. It's just going to be really straightforward. Actually, I found that actually doing guided knee injections was actually quite difficult until we started to master the whole thing about repositioning the knee in a bit of rotation to help the probe angle. You go straight for it and you've got a really steep needle angle, you're not going to see it. And it's when you start doing that as a novice, it's quite disconcerting and you can't see the needle yet it's inside the patient. You're trying to pick it up and everything else. But that ability to move your probe and say, okay, well, there's a big osteophyte there. There's no real joint there. I can't get in there. There's a bit of fluid there. If I get into fluid, I don't need to contact bone. It will flush into the joint. It's much better for the patient's comfort and accuracy of the technique as well, right? But that all then links back into what we're saying about just having this ultrasound skill before you start sort of leaping into to doing these guided procedures and things, because you can get unstuck. So I think we've fairly well kind of set our stall out on that one, haven't we, guys, in terms of what we think from our experiences and from working in educational spheres around this.
I feel that someone ought to sort of coming in the case against, it feels like a very unbalanced conversation.
It does, doesn't it? It does.
We all agree.
But I do. It's interesting though, isn't it? Because I do think when we do some of the courses that we do, I do think people come along to the course expecting it, say that, a cadaveric course or any injection course we're using sort of phantom devices. It is always the common thing. And the common theme is that people feel that it's a lot harder than they thought it was going to be. And that they feel to see the needle and to pick things up and to manipulate the probe. That's been a consistent message over the last 10 years.
Yeah.
And that's why we always recommend that people, consider and think strong and hard about developing these ultrasound skills, and don't just go down the route of just starting to do guided injections as an extension of doing landmark procedures as well.
Yeah. And we teach this and emphasize this a lot on the course, but using phantoms, I've got to say, the longer I've been teaching ultrasound guided injections for, the more I get, people that I'm training up to use phantoms, because I just think that moment where you've got your target structure on the screen and you need to enter the needle into the tissue.
Yeah.
That moment where you go in and then you then got to find that needle tip, don't move the probe, and we talk about the sort of the game of snooker, don't we, where you've got to have your needle lined up with your probe and your target structure all on the screen at the same time. And if it isn't, if you find yourself in the situation where your probe's there, you can either look at the needle or your target structure, then
absolutely. And as we said earlier, don't move the target structure, but that requires probe skills, right? To keep a steady image. As soon as that image moves, how are you going to inject the structure that you just saw on your image? It's difficult, isn't it?
It's such a crucial part of getting it right and having that confidence and that ability to follow in, pick the needle up nicely, advance the needle. So we've broken it down, haven't we, so many times for our students, that I guess we really sort of like are able to see all the sort of component parts
of it
on the floor. And it's just then sort of like, it's that thing about teaching people how to put it all together into that smooth act, and all the time you're clinically reasoning and managing the patient and all, and in the environment, and there's so much to think of. And again, I would say this, and such another really key reason for having that sort of really solid ultrasound confidence, dexterity and probe control, is that otherwise you just feel like you're trying to juggle so many things at once, and it takes a long time for it to become a smooth sort of process. I think if you're kind of having to think about the very act of performing an ultrasound, and the probe feels really awkward in your hand and you're struggling to optimize the image, trying to do that and do an injection whilst maintaining a sterile field around what you're doing is tricky.
Tricky. But I think what we've talked about is basically skills, but that we talked about the time frame of that. And I think there's no harm, even if you've done courses or even certified courses, acquiring these competencies, that you still probably, as you said, Dave, earlier, that for a carpal tunnel, you might not do them for a year or more maybe even, you might be just doing other areas that you feel comfortable with as you're learning. There's no harm in sort of wanting to sort of rush into doing the whole range of the skills.
Brilliant. I think that's some really, really good points there, guys. And I hope that people listening understand the angle that we're taking with that. And we're not, I don't think we've been necessarily obstructive to people developing these skills in the slightest. I think that once you've been sort of involved in education around it, and you've taught hundreds of people in reality now, we understand some of the challenges of doing it, and the right way we think that people should go about doing things.
We'll edit in some counterbalancing arguments in the post-edit,
so thanks for your thoughts, guys. I've just realised that this Sunday it's the North London derby, I think, Dave, isn't it? So with me as a Spurs fan and you as an Arsenal fan, we might not be back on here next week, depending on what happens. Could be interesting. I think you've got a few injuries in your squad that might be of concern to you. I thought you looked a bit nervous this evening.
I've got to give you a chance, mate. I've got to give you a chance.
Or Rob stuck in the middle. But anyway, let's wrap it up. So it's only MSK Ultrasound podcast again. I hope you've all enjoyed it. My name's Stuart Wildman.
My name's still David Baker.
My name is still Rob Mast.
Super. Lovely. And we'll see you all soon, hopefully. Thanks very much.
Yeah, bye.
Bye.